I'm a doctor and public health worker with more years than I care to mention with Médecins Sans Frontières, working in humanitarian settings around the world. And I'm director of the Southern Africa Medical Unit of MSF, which supports our global HIV/TB programming. I'm really delighted to be at this fascinating presentation, and thanks to the organizers for inviting me to co-moderate. We're going to be quite strict with the timing, and that's why I've started as close to time as possible. But please do post questions as we go in the Q&A. I assume that you're all quite au fait with working with Zoom by now, but ideally the Q&A, but we'll also look at the chat. And we will, my co-moderator and I will ask the questions on your behalf. I think this is a really appropriate time for this discussion. We're in the middle of an unprecedented global humanitarian emergency, and we're experiencing the highest numbers of displaced people globally ever. The first framing of differentiated service delivery was always client-centered, but it was really focused on the stable, the people who were doing well and making things simpler and more focused on their needs. But we have this slogan of leaving no one behind, and that required those working in programming, and particularly in differentiated service delivery, to think about how can we go beyond the stable patient in the stable setting and adapt services to those who are being left behind, either because they're in conflict and humanitarian settings, or they are being affected by emergencies and having to move, or being mobile for other reasons. So with that said, I'm excited that we're going to have three excellent presentations. And I'd like to introduce Veronica Mugisha, my co-moderator, who is the country director of ICAP in Rwanda. She's a physician and a public health specialist with over 30 years of clinical research, program management experience. Veronica, over to you.
Thank you very much, Tom. Good morning, good afternoon, everyone. It is my pleasure to be your moderator today, and I'll be working aside with Tom to navigate you through this very interesting session on DSD for mobile, migrant, and displaced populations. We have four panelists for today. We have Dr. Mariam Rabukin, who is an associate professor of medicine and epidemiology at the Merriman School of Public Health and the director for health systems strategies at ICAP, where she's the PI of the Sequin project. We also have a presentation from a physician with 16 years of experience in Nigeria's HIV response. He's currently the technical director for the USAID-funded RISE project in ICAP, Nigeria. We will get another presentation from Dr. Dario Ali, who is a DSD coordinator with the Ministry of Health in Mozambique. Prior to joining this role, Dr. Dario worked with ICAP in Mozambique for 8 years. We have finally Dr. Shambe Gao, who is the technical advisor for ICAP in South Sudan. He will be standing in for Dr. Victoria Achut, the program manager for HIV/AIDS and STIs department within the Ministry of Health of South Sudan, who unfortunately is indisposed and unable to join us today. But they are working very close together, and we are sure he will be able to give us a good run through of the challenges and the experience they have gone through in Southern Sudan. I will note before inviting Mariam that Southern Sudan is not yet a member of the Sequin network, but they have gone through the experience of applying the DSD approach in a very difficult situation involving conflict and wars, and her experience is going to be enlightening to us. So without further ado, I will invite Mariam to make us a presentation. Please, Dr. Mariam.
Thank you very much. I am just going to make some very brief framing remarks. Next slide. And I say an outline, it's really, again, it's a very short talk. It's more for us to think together about this relatively new topic for Sequin. This is something that we've been talking about for a while, but we haven't really launched a community of practice. And so one of the things that I'd love for us to talk about when we're on this session is why should we consider these groups of people when we think about DSD? I think that's pretty obvious, but important to think about. What are the issues and challenges that are specific to migrant, mobile, and displaced people with regard to accessing HIV services, and what models meet their needs? Next slide. So to sort of label a session, mobile, migrant, and displaced populations is to create sort of a very big group of people, right? So this includes a very diverse set of people. Some people not only diverse in terms of why they're on the move or for how long they're moving, but sort of how emergent the moving is. And so next slide, I wanted to just highlight that these are, you know, not always people that we should combine when we think about models, but one topic, which Tom mentioned as well, is the idea of HIV and humanitarian emergencies. So there already is an interagency task team on HIV in humanitarian emergencies, which is composed of UNAIDS, UNHCR, the World Food Program, UNICEF, UNFPA, WHO, and probably others. And this is a figure that I took from one of their reports, which really just highlighted the fact that a lot of people living with HIV were affected by a humanitarian emergency in 2016, probably more in 2020. And that's because of the point that Tom made, which is just there are more displaced people now than ever before. Next slide. There's also, right, UNHCR focuses on people who are forcibly displaced, whether this is within or between countries. And so this is, these may be asylum seekers, refugees, people who are leaving for reasons that could include humanitarian emergencies, but also could include other causes like political causes. Next slide. And then when we talk about sort of mobile populations or migrant populations, people move for economic reasons as well within countries and between countries. And just some examples that came to my mind when I was making the slide are, right, the sort of mining industry, people going back and forth across borders, people travel for agricultural or farm work, there are pastoralist communities or mobile communities, lots of other reasons why people move within and between countries. And these can be people who are documented or undocumented, people who are moving for reasons that might be considered legal or illegal. So it's a really diverse population. Next slide. Trying to think about barriers, they're not all shared, right? Not everybody in these groups has the same barriers, but there's clearly an important one is intermittent access to services. There's conflicts between what might be an immediate priority, you know, putting food on the table today versus a longer term priority, accessing an uninterrupted supply of ART. There's failures within countries, in some cases within cities from in terms of sharing records, and certainly between countries. There can be real difficulties if you are receiving treatment in one country and are currently in another. Displaced people also have lack of resources in current languages or in the languages that they speak or in the correct cultural context. There's sort of dual stigma and discrimination, sometimes both from HIV and from being displaced. There's in some contexts, the linkage of rights to citizenship. So if you don't have papers, you don't have the right to access health services. And in some contexts, this is complicated even more by criminalization. Next slide. So we know that differentiated service delivery, as Tom said, is not just for people who are thriving on ART or people who are, quote, in a stable category. And even in this original figure from several years ago now from IAS, there is at that sort of, I don't know, 6:30 o'clock, the sort of piece of this pie that says unstable context. So high migration settings, conflict settings, and others. So we're not suggesting by having this panel that there's one DSD model that everybody in this category, but to say that it's critically important if we're going to leave no one behind to think about these categories of people who fall in and out of these groups. And I'll note that we're going to have 3 great case studies today And they focus on displacement due to violence and climate emergency, not to the longer term displacement. So we're really only starting the discussion. Next slide. So last slide, just while you listen to the case studies, one of our questions is, should Sequin launch a community of practice on differentiated service delivery for mobile migrant and/or displaced populations? Should we have a series of webinars? Should we have an opt-in community that continues to exchange ideas and best practices or works together to create resources and tools? And if so, why, right? There's a lot of other people in this space. That's one of the reasons why we haven't done this before. But what is missing that Sequin can provide? We're not necessarily going to come back to those questions in this hour, but just as an underlying theme, we'll certainly come back to them. I think that's it. Yes. So we'll just go directly to Dr. Fadari from ICAP at Columbia University.
Thank you. Good afternoon from Nigeria. My name is Wale Fadari once again, and I'll be speaking to you about our experience on the RISE project, providing DSD services for people displaced by violent emergencies in northern Nigeria. So this is the presentation outline I'll use. I'll give a very high level overview of our program in Nigeria, as well as set the scene for the security challenges that we faced in the course of implementing the RISE projects. Then give a very brief situation analysis of how these security challenges have affected our ability to not just provide less intense models of care, DSD care to recipients of care, but also how it has affected our ability to reach patients with the services that are designed for them. Then finally, we'll look at some success stories and strategies that we've used to close these gaps in the outgone year. Next, please. Okay, so RISE is an acronym for Reaching Impact, Saturation, and Epidemic Control. It's a USAID funded grant that is implemented by ICAP and JAPIGO. It's a multi-country award, but the Nigeria program is implemented across 4 geographic locations in the country. At the end of APR 20, we had a TX score of about 70,000 patients, but next slide, please. The story that I'll be telling you about today will focus on these 2 states in green and in blue. We'll focus on the 2 states in green and in blue, Adamawa State and Niger State. Next slide. So you have the 2 geographic locations, one in the Northeast, in Adamawa, where we support about 26,000 patients. Now, the Northeastern corridor of Nigeria, as many will know, is the theater of operations for the Boko Haram insurgency. And that has severely affected our ability to reach patients using mechanisms that allow them to receive care where they live and work. The theater in the Northeast is significantly more affected. And this has been running for about 10 years or so. And in the other states, Niger State, there's also been that impact, but to a lesser degree, with not necessarily religious fundamentalism, but access that was limited due to headsmen, marauding headsmen, and violence in some of these locations. Now, you now layer on top of that recent challenges that we're all familiar with from 2020, restrictions in movement due to the COVID, the huge landmass in these 2 locations that we're talking about in Nigeria, and how this has affected our ability to reach patients. It's critical to mention that many of these communities, access to them is severely limited, and sometimes the only way to go in there is with an armed escort. It also means that convening meetings, whether support group meetings or any of the DSD models that we're more familiar with that are implemented in the community, these kind of platforms are difficult to implement. There's also a concomitant increase in the cost of doing business in these regions. Organizing things as simple as a meeting or a training is significantly more expensive than what we're used to. Then I think something that is critical to mention are challenges around reporting and ensuring that the data that we receive and report on is high quality and is representative of the work that we do. The challenges with access make it difficult for us to have that. We need to go the extra mile to validate the data and make sure that it's representative of the work that we do. One of the early things that we did in trying to better categorize patients was to identify vulnerabilities. So in these regions, this particular slide, the vulnerability profile on the right was information that we used to drill down into specific risk factors that increased, that was suggestive of patients that were more likely to experience an interruption in care. Now, this profile fits in the communities in both the Northeast and Northwestern Nigeria. And another strategy that we used was looking at patients who resumed therapy, returned to care. And when we were onboarding them back into the program, interviews that were conducted elicited a similar or feedback was suggestive that particular contributing factors were responsible for them being away from the health facility or being unable to meet up with their appointments. And for us, all of this just stressed the need for a different way of supporting these patients to be able to access care, regardless of where they were in these communities that we were supporting. Next, please. So again, like we've been saying since the SICWIN conference started yesterday, multi-month dispensing, and over the next couple of charts, I think we're just going to do a case study of children and adolescents in these communities in Niger and Adamawa states, but particularly over the next 2 or 3 charts, I just want to stress that one of the things that we did was a ramping up of multi-month dispensing. When the project started off, we had really, really low numbers of children and young adults who were on multi-month dispensing. And over the course of the first year, we're able to transit these numbers to as high as 80% for this cohort. We also were able to scale up viral load sample collection and the use of viremia clinics for patients who are virally unsuppressed. And all of this was done in that setting of displacement and insecurity in the Northeast and Northwestern Nigeria. Next slide. Then a key finding for us was comparing our viral load suppression between Q1 and Q3 for last FY, and we're able to demonstrate significant increases in viral suppression for this cohort of patients. And it's an application of many of the strategies that we know: regimen optimization, proper use of weight bands in regimen prescription and dispensing. But what was really critical was the ability to go above and beyond the service within the clinical setting and design interventions that could fit into a DSD model that was very unstable. Often we were using structures that were not orthodox or convenient, but that realization that you had to find a way to provide these services using the limited resources you had were just critical for our success. So again, specifically, I tried to paint a scenario of the challenges that we faced, but how did we address them? How did we go around them to ensure that these services that I just mentioned were instituted? I think the first one was maintaining, because of the security risk, it's critical to maintain good communication with the high-risk locations so that travel and site visits were regulated as much as possible. And only when we had clear approvals to travel to these locations would we go in. Security trainings were mandatory for the regional teams. And essentially, the work that we did was very low profile, inconspicuous, just going around in the community, particularly using community members to do the work. But I think something that was of tremendous impact for us was using technology to set up virtual discussion spots. So we could have meetings on Zoom, we could have meetings on WhatsApp, we could have meetings, we had SMS templates that we used for sending in reports. And I think this was really helpful in just making sure that there was that open channel of communication and we were reviewing the work that we were doing. Next, please. So specifically for the strategies that we used, I'll just want to focus a bit on our strategies for maintaining patients on care. And from the very beginning, from the point of identification, we used what we call a menu approach. And depending on where these patients were located in these two states, patients were offered a menu of pickup locations. Now, like I said, many of them were not orthodox service delivery platforms. Some of them were the community ART groups that many of us are familiar with, but oftentimes they were not led by a PLA or they were not led by a healthcare worker. We also prioritized MMD. I've already spoken about how we took MMD to about 80% for children and adolescents. And one key strategy that was very helpful in the Northeast was ARV front loading. So when we're approaching religious holidays or there are particular times when it's like harvest time, when there's an increased chance of communities being attacked, we try to reduce the pressure on recipients of care to access their ARVs by front loading them with those medications. So they don't need to be in high risk locations. They don't need to come into the hospital to get their ARV pickup. Next, please. So again, looking forward into the new year or the current year, there are about two or three initiatives that we're putting into play with the PEPFAR team in Nigeria. And one of them is a PEPFAR-driven interagency delivery network. The sub-national units in Nigeria are regionalized with different implementing partners in different locations. And that overlap, so if you have a patient, for example, in one location that is not where your organization is providing support, it can be a bit of a challenge. So working with PEPFAR, we've been able to set up a mechanism where regardless of where a patient is located or which implementing partner is supporting that community or that sub-national unit, it's possible to get a pickup. And all that needs to be presented are the unique IDs and maybe a biometric scan, because we have biometrics being rolled out across the country. The second key point has to do with safe zones. Safe zones refer to like backup service delivery platforms, such that if the ability of a clinical platform to provide care is compromised, there's a backup location that will allow services to be delivered. And we're looking, because of the trust that religious and community leaders have, we're trying to see how we can use them to penetrate into militarized locations so that they can also serve as ARV distributors or coordinators of community ART groups. Next, please. So I think this is my last slide, and it just to reemphasize something that one of my colleagues said a lot. We use every contact session, particularly across RISE as a whole, but particularly in the Northeast, we use every contact session to provide an integrated health approach from first 95 to the third, where we're eliciting for index, we're reinforcing adherence, we're ensuring that viral load draws are done, and just making sure that everybody sees themselves as part of the clinical care team, regardless of what your primary intervention will be, whether a lab scientist or a case manager. And I think this has helped us tremendously to achieve the results that we saw in the outgone year. And I think that's my last slide. Thank you.
Thank you very much, Dr. Wali, for such an enlightening presentation. Before I invite our next presenter, I'd like to invite all the participants, please type in your questions in the chat box, and then we will present them for you to the panelists when the Q&A session begins. So now I have the pleasure to invite Dr. Dalio Ali, the DSD coordinator from the Ministry of Health of Mozambique, to present to us about the Mozambican experience with DSD. Dr. Dali, please.
Thank you. Hi, as said, my name is Dario Lee, and I'll be talking about our DSD for displaced populations. Next slide, please. So, despite all the efforts of the country to guarantee access to HIV services, we still struggle with some challenge: infrastructure, human resources, quality of services, and as well as adherence and retention that it's quite low. In this context, we developed our and implemented our guidance to differentiated service models in 2018 to try and maximize existing resources. Next slide, please.
Dario, I'm very sorry to interrupt, but you're quite faint. Can you get closer to the microphone?
Okay, I'll try.
Thank you.
Is it better?
A little better, yes.
So for models, we have several. The first one indicated is appointment spacing. We have 3 and 6 multi-month drug dispensing. We have CAGs. We have ARV distribution integrated in mobile brigades. We have adherence clubs. We have ARV distribution through community and health workers and through healthcare workers. Next slide, please. So last year we had 2 natural disasters, Cyclone Idai and Cyclone Kenneth in Sofala and Cabo Delgado provinces. And we also have, since 2017, military attacks in the northern province of Cabo Delgado. These have been increasing since the last year. All of this has led to a great increase in the number of people living with HIV. Next slide, please. We made some interventions during Idai. So the cyclone impact was measured through weekly monitoring, and frequent visits to high volume sites were made to access challenges in ARV drug pickups. So from these 2 interventions, we made recommendations, and nearly all health facilities were able to provide HIV services, including drug dispensing, in the week following the cyclone. So what were the key steps taken during Idai? We repurposed undamaged space for consultation and for pharmacies. We did on-site training on administration of non-culture independent ARV regimens, and we provided mechanisms for drug dispensings for those patients or recipients of care who lost their health card or even clinical files. Next slide, please. And in the internal displaced camps, we had 3 models. In some, we had temporary health posts. We used the community health workers to dispense ARVs, and there were also mobile brigades. Next slide, please. So this graph shows that there was a big drop on the number of ARV pickups during the cyclone Idai, and as a result of our interventions, you can see after the drop the numbers went up. This is a direct result of our interventions. Next slide. As I said before, we have since 2017 military attacks in the northern province of Cabo Delgado, and 9 districts have been affected, with 36 health facilities closed and others working conditionally. Because of these attacks, more than 200,000 people have been internally displaced since July this year. These include people living with HIV. Next slide, please. And all this displacement has led to big drops in our indicators. As you can see from both graphs in your left, this is data. These are data from conflict areas, and the graphs on your right are data from the areas without conflict. The top left graph shows the number of people counseled and tested for HIV, and you can see from July to September last year to July to September this year, there was a drop of 70% on number of people tested. When compared to the areas without conflict, there was a slight increase in the number of people tested. The same effect is seen on the number of people currently on ART. The bottom left graph shows that there was an increase of over 50%, a decrease of over 50% of people currently on ART on the conflict areas when compared to the areas without conflict, where there was an increase of 18%. Next slide. The same effect is seen on our other indicators, as you can see from these graphs. The upper graph, you can see the drop on the viral load samples. The same is seen on institutional deliveries and EID PCR samples. All of these indicators have dropped in the areas with conflict and somehow went up in the areas without conflict. Next slide, please. So we have interventions for the areas with conflict and interventions for the areas without conflict. In the areas without conflict, there is a coordinated approach, and there are multi-pronged approaches being implemented by the local authorities, implementing partners, and other partners. These include weekly coordination meetings to discuss challenges and solutions, recipient of care tracking in the community and referral to the health facilities, weekly recipient of care tracking in internally displaced camps, and collaboration between provinces to trace displaced recipients of care. Next slide. And in the areas without conflict, there are several interventions being made. Naming them, testing is being essentially done by the community health workers. Mobile brigades are offering HIV testing services, are also offering care and treatment. There is an interprovincial commission to track recipients of care and actualize the transfer status. The same community health workers are distributing ARVs. EID is being done in mobile brigades, and there is collaboration between mental mothers and traditional midwives. We still are doing reintegration of recipients of care through home visits, and those who default and are not able to go to the health facility are being included in the community distribution. Next slide, please. So what are the next steps we want to take? We are analyzing the possibility of including Red Cross and MSF in the affected areas. We are on the process of developing a passport that will be given to each recipient of care so they can access services everywhere. We are creating a simplified register for these displaced recipients of care. This register will capture some indicators. We are adapting the existing models or creating new ones to better serve these displaced populations. Next slide, please. As a conclusion, despite the widespread damage done by the cyclones, the immediate site assessments and technical assistance were key to minimize the disruption of services and to ensure the continuity of care. It was possible to provide ARVs for people living HIV affected by the cyclones, despite being in the internally displaced camps. There are a lot of actions being implemented to reach the displaced populations. In the areas affected by the conflict, it's more difficult to reach recipients of care. And despite all the efforts, the models available are not able to reach all recipients of care. Additional efforts are being taken and have to be taken to reach a greater number of displaced population. Thank you. Please feel free to ask questions.
Thank you very much, Dr. Dario. I will now invite Dr. Shaber, the technical advisor for ICAP in Southern Sudan, to share with us the experience of South Sudan in terms of implementing DSD services for displaced populations. Dr. Shaber, as I said earlier, will be presenting on behalf of Dr. Victoria, who is indisposed. Please, you have the floor.
Good. Thank you. Good morning, good afternoon, and good evening, everyone. It is our pleasure to present the South Sudan's experience in the delivery of HIV services in a conflict situation resulting in mass displacement. Next slide, please. So the outline would be just a brief introduction of South Sudan and the current HIV epidemic status, and then the active conflict in 2013, and then the impact, the effect on our HIV national HIV response, and then in the aftermath of the first bout of conflict in 2013. There were a series of response measures that the national program took, and then and what were the DSD models that we put in place, measures that we put in place for addressing those populations. And then there was a second bout of conflict in 2016, and then with that, what were the benefits that we have seen from the responses and the preparations that we did, and the lessons learned from the first conflict in 2013. So this will be the outline. Next slide. Yeah, South Sudan, the Republic of South is the youngest nation in the world, and it became independent in 2011 after 2 decades of civil war with Sudan. But just 2 years down the line, after independence, a conflict erupted in 2013, December 2013, and another active conflict also in 2016. And the 2013 and the two wars actually caused displacement of nearly 4 million people in South Sudan, and half of them internally displaced into the different camps for protection of civilians, and half of them left the country to the neighboring countries, including Uganda, nearly 1 million, and also followed by Sudan and Ethiopia, and a few into Kenya as well, and also others in the DRC and Central African Republic. Next slide. So the South Sudan, with the population of 11 million, the prevalence of the HIV prevalence stands at 2.5%, and there are an estimated 190,000 people living with HIV. Despite the steady improvement in uptake and quality of services, South Sudan has a lot to do towards the 95 targets. Currently, it stands at 24, 16, and percent first and second 95, and the viral suppression with the very low coverage stands at 73%. And weak health system with limited HRH capacity number, as well as quality and supply chain issues due to systems and as well as the general infrastructure are the main bottlenecks for HIV service delivery in South Sudan. Next slide. So with the first conflict in 2013 came after a euphoria of an independent nation newly created after a landslide referendum. So the 2013 conflict came very unexpectedly, and nobody anticipated, including the Ministry of Affairs and the HIV. The development partners didn't expect the 2013 conflict. So when it erupted suddenly, Ministry of Health and its partners and patients were not ready. As a result, many patients were cut from the health facilities, and no community service delivery networks were available at that point. And then immediately, stocks of ARVs were very low and then quickly ran out. And also the small amounts which were in the warehouse made it, the warehouse, even the national warehouse was not accessible because this conflict was, the epicenter was within the capital. So there are no regional warehouses. So even it was difficult to access the small stocks that we had. Many healthcare workers and PLHIV people living with HIV also get displaced, and many left to, as I said, to the neighboring countries, but a considerable number to the many displacement camps, IDP camps in country. Health facilities were looted, patient records were damaged in many health facilities. Next slide. So in the aftermath of the immediate the aftermath of the conflict, Ministry of Health, WHO, and the ICAP and other partners started to mitigate the effect of the situation on patients. And the discussions started with the humanitarian organizations, including MSF, IMC, IRC, and also many of the UN agencies. Including the United Nations Mission in South Sudan, IOM, and the UNHCR, to move available commodities to functional facilities and IDP locations. And they also work with collaboration with the PLHIV groups really to reach and reestablish communication among patients, and develop guidance on how to manage patients in situations of stockouts. Many facilities. So while many facilities were directly, but the supply chain interruption also affected facilities which were open, still open, but they don't have drugs. So we started also, we developed guidance on how to manage patients in the situation of stockouts, how to interrupt safely, and whom to prioritize with the small number of available supplies and so forth. Next. MOH, and then we started also, in addition to mitigating the immediate impact, we also started to prepare for the future. MOH has developed guidelines for minimum package of care during emergency and a crisis. And MOH with the partners also, including like UNAIDS, UN OCHA, ICAP, WHO, and developed contingency plan for continuity of services during crisis situation. And integration of the contingency plan in the different SOPs, including the supply chain SOP, and also the national consolidated HIV guideline, and in the different thematic trainings for HIV, where we integrated the contingency plan. And training of engagement of humanitarian organizations, which are classically activated during active ongoing conflict, the minimum package of TB HIV services during emergency situations were also done. And also the emergency TB HIV technical working group was established. This technical working group is an addition to the national HIV technical working group, but involving mainly the humanitarian organizations. Next slide. So the specific activities which were undertaken are repositioning of ARVs to regional labs. Regional hubs. So to mitigate, because the warehouse was so centralized, and it was in the capital, and the conflict was in the capital. So pre-positioning of ARV to the different regional hubs. Though there were no formal warehouses, we opted bigger hospitals with relatively better warehousing to be our pre-positioning facilities. And also developed patient ID card with key HIV treatment information, so that people can access treatment wherever they are, if they manage to reach other facilities, including outside the country. And training of healthcare workers in patient communication for impending crisis. So we trained the healthcare workers on scripts how to communicate with patients, and asking simple questions. If a conflict erupts, which way are you planning to go, the most likely path, and what are the facilities which are nearby or across the border, and also sharing a directory of facilities. And so healthcare workers are trained on those packages. And displaced healthcare workers and expert clients also were trained on establishing contacts with re-establishing the contact with Ministry of Health, and also with the partners to continue services in camps and destination points. And the other action was engagement of PLHIV groups in tracking displaced peers in IDP camps and even refugee camps across the border. Cross-border collaboration were activated through IGAD and PEPFAR supported services provision, like in the one in northern Uganda, or where nearly 1 million South Sudanese were housed. And engagement of health cluster partners, as we've said earlier, and also with the HIV department, Ministry of Health, and the development partners, the typical HIV partners, started to participate in the health cluster meetings, which comprises of mainly the humanitarian emergency partners, UNIMIS, WHOIM, and UNHCR. Also were very helpful in ensuring transporting the drugs to the different campuses. Next slide. So then, while this was going on, then active conflict in 2016 again happened. Started in the capital, and there were tensions ahead of the 2016 conflict, and also after the 2013 conflict, there was a peace pact that was signed by the different the main opposition and the government. And when the peace was established, the transitional government was established, there were 2 armies already in town. So it was unanticipated relatively as opposed to the first. So, but when this conflict happened, operations that we were able to accomplish after following the 2013 conflict were really rewarding. And there were no major stockouts at a national and at a facility. due to we are prepared at a national level, having more stock, and at the same time, because of the pre-positioning that was done with the different hubs, facilities were able to pick their supplies from the pre-positioned facilities. Patients were given multi-month dispensing ahead of the active conflict, and healthcare worker training, patient communication, and the PLHIV networks and CSOs were better prepared to cope, and it took less time to recover. Next. Thank you so much.
Okay, thank you so much, Dr. Shambel. This is a very interesting session, and it has taken us to the Q&A session. Unfortunately, we have eaten a lot of our time, but we recognize how interesting it is. So we'll begin up with some of the questions from the audience. I will invite the panelists to be as brief as possible so that we can try to answer as many questions as possible. And to kick off this session, I will begin with a question from our colleague Clorata from Zimbabwe Ministry of Health. It is addressed to Dr. Wale. And this is the question. It appears that DSD implementation in these high-risk areas is resource intense. How is resource mobilization structured for this? And is service provision sustainable in the long run? What would need to happen long term to ensure long term sustainability? That is for Dr. Wale, please. Dr. Wale?
Yes, thank you, Clorata. So, I mean, sustainability for for DSD models in high-risk locations. Currently, at least in our own experience, we have funding that doesn't come to support the interventions that we do. A lot of the things that we do in these communities are looking out for community structures, platforms that people trust, community leaders, and to my mind, I think that's just the most efficient model and the most sustainable model for us to use to be able to deliver ART services despite these conflicts. Ideally, it would be most ideal if we didn't have this crisis that would force us into these very challenging implementation strategies. But other things that we can look at are resources that are available in those communities. So the trust and the respect that communities have for their faith leaders, for their traditional leaders. Some other things that we can do, like I said in my presentation, was to look at patient journey maps, places where in a given locality where recipients of care are likely going to go to access services, whether there's a conflict going on or not. So it makes sense to target those platforms and use those platforms to run off DSD models or ART pickup models that are more sustainable in the long term.
Thanks. Okay, so we are really running short of time, and most of the questions have been answered in the Q&A. I wanted just to reflect a couple of them and perhaps put one more question to the panelists. So there's a very interesting question around the challenges of monitoring mobile populations. And Martin reminds us that it's not just in conflict and in humanitarian emergencies. Commercial sex workers and many others are constantly mobile. So learning and sharing these experiences. But a specific point that you raised around the problems of supply chain and the critical role that monitoring has in justifying a supply chain, however difficult it is to manage a supply chain, particularly for 6-month refills, which of course are even more necessary, just reminds us of the complexity of the settings. And I'm really amazed by the presentations you've had, fantastic experiences, and also this rare opportunity to actually describe what you're seeing. So thanks so much for that. I just wanted to pose one question since we're at time, and it's really, how do we share these best practices? Sequin is all about communities of practice, and even this session which mentions mobile populations, displaced and migrant, doesn't actually use the word conflict. And yet all three of our presentations were talking about the particular complexities of delivering services for conflict-affected populations, not all of whom are mobile, migrant or displaced. And in fact, the ones who are not moving often have the least access. And we saw that nicely presented, I think, from Mozambique. So I wonder, what is the best practice that we want to share? And I wonder if you could quickly give any reflections on how Sequin and others should take forward this desperate need for sharing and learning for the experiences of these populations. Perhaps I could put that to Dario first.
Thanks, Tom. So I think Sequin could help us by providing, instead of webinars, maybe small workshops with 2 or 3 countries who are sharing the same problems. We have conflicts here, and other countries have described their conflicts. Some have more, I could say, mature answers. Maybe Sequin could be the one facilitating discussions between these 2 countries and trying to share tools, experiences. Even we have had the opportunities to talk to Nigeria, for example, and I think these are really great. I'm not talking about webinars, but I'm talking about close discussions. Unfortunately, this discussion cannot be face-to-face, but we have this platform, Zoom, and Sequin could provide this space for us and try to moderate and try to lead these discussions in a way that we can maximize results. Thanks, Tom.
Okay, thank you. Would any of the other panelists like to chip in? I give you 5 seconds to jump in if you would.
Yes.
Otherwise, go ahead. Go ahead.
Yeah. Thanks. This was a very nice experience for us to share, and also I think the main take-home message is from here is a patient agency. Really, in whatever situation across the board, I mean. Including those, rare topics like displacement and, man-made or natural calamities. Patient agency, empowering patients is really to handle, discussing with them very clearly what their plans are forward is something really that we can take. And also integration of HIV and other chronic illnesses into humanity. These are some experiences that also should really be, we have to pick and take forward. Thank you.
Okay, thank you very much.
Sorry, go.
Yes, Tom?
No, go ahead, Veronica.
Yeah, so thank you very much. I want to thank our panelists, but as well as our participants. Thank you for very lively presentation and discussions. I'm sure we would have liked to continue, but because of the time factor, we have to close our sessions at this point. Please, you have emails. If you have any questions, don't hesitate to keep sending them in. They will be responded to in due time. Before I close the session, I would like to remind you and invite you for tomorrow's session. Tomorrow, we start the day with a plenary on COVID and DSD. The session will start at 7 a.m. New York time. So please be there at noon Freetown, 2 p.m. Joburg, and the 3 p.m. Nairobi time, or 2 p.m. Central African time. See you there. Have a nice day, a nice evening for everyone.
Thanks, everyone.
Bye-bye.